Hello, and welcome back to another edition of the University of Alberta Plastic Surgery Webcast series, created by Dr. Gordon Wilkes, Dr. Kevin Mowbray, and Ashley Matkin. In this webcast, we'll be discussing phalangeal injuries, specifically fractures and dislocations. This webcast is an extension of the hand trauma presentation given by Dr. Gordon Wilkes and is intended for those who wish to learn more specific treatment options. This webcast was written by myself, Ashley Matkin, and edited by Dr. Brandon Ball. A brief overview of today's webcast includes a refresher on hand anatomy and classifications of fractures, along with their indications for treatment. We will then move on to the distal phalanx fractures and fractures of the shaft, condyles, head, and base of the middle and proximal phalanges, discussing how these fractures arise and how to treat them. We will then cover similar information for dislocations of the interphalangeal joints. We are starting off with a quick refresher of hand anatomy and the terminology that will be used in this talk. The hand is composed of 19 bones and 19 joints. The bones consist of carpals, metacarpals, and phalanges, and the joints are named respective to the bones they are joining. Today, we will be focusing on phalanges and interphalangeal joints. Each phalanx is named respective to its proximity to the limb. There are the proximal phalanges in contact with the metacarpals. The middle phalanges come next, followed by the distal phalanges, which form the tips of the fingers. Similarly, the joints are named according to which phalanges they connect. There is the proximal interphalangeal, or PIP, joint between the proximal and middle phalanges, and the distal interphalangeal, or DIP, joint connecting the middle and distal phalanges. The interphalangeal joints are stabilized by a volar plate, which is essentially a thick ligament that limits extension, and two collateral ligaments which stabilize the joint by connecting the lateral aspect of the head of one phalanx to the palmar aspect of the base of the adjacent one. When a patient presents with a hand injury, it is important to gather a history related to the use of the hand. Some important questions to ask are the age and handedness of the individual, as this may affect the patient's compliance with rehabilitation. The time and mechanism of injury are important factors in deciding how to treat, especially as most reductions become more complicated as time since the injury lengthens. Knowing the patient's occupational or vocational status will help you to determine when they can return to work, and knowledge of previous hand trauma may affect treatment and recovery times. Tetanus status is especially important in open fractures. In order to correctly diagnose a hand fracture, the physical exam and radiology are essential. On physical exam, examine for tenderness, edema, deformity, neurovascular status, especially important when deciding on what type of reduction to perform, and associated lacerations. It is also important to look for scissoring or rotational deformity. Ask the patient to put the injured digit through a gentle active range of motion. A rotational deformity is demonstrated when the injured digit crosses over other digits. Obtain both pre- and post-reduction x-rays from the PA, lateral, and oblique views to get a clear view of the injury and the reduction. Clear treatment goals are very important when approaching a hand fracture of any sort. Maximizing function and minimizing deformity will improve the patient's quality of life. Similarly, to avoid surgical complications and risks, only choose operative treatment if its outcome is better than that of non-operative treatment. It is important to reduce and stabilize fractures in a way that will be maintained following the removal of splints or K-wires, and ensure the patient understands the need for rehabilitation to restore hand function. If you choose to treat operatively, ensure the fixation is stable enough to allow early motion to avoid loss of function. We will now be talking specifically about fractures of the phalanges, followed by discussion of interphalangeal joint injuries. Phalangeal fractures often do not present acutely and are frequently missed on initial exam. Their instability is determined by the configuration of the fracture, the condition of the periosteum and surrounding soft tissue sleeve, as well as the muscle balance around the fracture. Fractures can occur in any of the 14 phalanges of each hand. Typically, they are first categorized by which bone has been fractured. That is, the distal phalanx versus the middle or proximal phalanx. Middle and proximal phalangeal fractures are then further divided into condylar, involving the rounded end of the bone, shaft, or base fractures. The decision to reduce a fracture, with or without fixation, operatively or externally, relies on a number of factors, including the classification of the fracture. Generally, we look at four main categories of classification. whether the fracture is open or closed, if it is articular or non-articular, if it is a simple fracture or comminuted, and what the pattern of the fracture is, that is, transverse, spiral, or oblique. Open fractures are either accompanied by an external wound leading to the site of the fracture or are fractures in which the bone fragment protrudes through the skin. Closed fractures do not involve external wounds. Articular fractures involve the joint of the bone. They can be displaced when a fragment of the bone shifts away from its anatomical position or non-displaced. Extra-articular fractures occur just outside of the joint, while intra-articular fractures are those that occur within the portion of the bone involved in the joint. Comminuted fractures are those which result in the bone being splintered or broken into pieces. Simple fractures can occur in a variety of patterns, including transverse, spiral, or oblique. Whenever possible, you should choose to reduce fractures with the closed technique. Most non-displaced or minimally displaced hand fractures can be treated conservatively. There are certain situations, however, when operative fixation is indicated. If the fracture is non-reducible with a closed technique, proceed to open reduction. If there is significant displacement, angulation, or rotational deformity that fails closed reduction, then operative treatment is also indicated. For open injuries, or injuries with associated soft tissue injury, operative treatment is indicated if an acceptable reduction cannot be obtained with closed means. There are a number of complications associated with hand fractures, with the most common being stiffness caused by adhesions forming between bones or hardware and tendon. Infections may also occur, particularly in open fractures or those reduced surgically. Malunion, or the healing of the fracture in an abnormal position, as we see here, can occur following fixation and can be both a functional and an aesthetic problem. Common malunions include dorsal angulation, malrotation, intra-articular malunions, and osteomyelitis. Angular and rotational malunions often need to be corrected surgically as they can cause severe dysfunction. Non-union, represented on the left, or the permanent failure of the fracture to heal, is less common and often occurs with infection, significant bone loss, or severe soft tissue injury. Compartment syndrome is very uncommon in hand fractures, but can occur in the setting of crush injuries. For more on compartment syndrome, please refer to our compartment syndrome webcast. We will now focus on specific fractures of the phalanges, beginning with distal phalanx fractures. Distal phalanx fractures are the most common of the phalangeal fractures, especially fractures of the tuft, or the very tip of the finger. Tuft fractures are a condylar fracture of the tip of the distal phalanx. They are classified as simple or comminuted. Fractures of the shaft of the distal phalanx are generally transverse or longitudinal. Intra-articular distal phalanx fractures are more complicated and tend to occur along with acute tendon injuries. These are called mallet injuries and will be covered in the joint injuries portion of this presentation. Treatment of phalangeal fractures depends on the type of fracture. Tuft fractures rarely require internal fixation. Mobilization for 10 to 12 days can be utilized for symptomatic relief, and in this time, fibrous union may occur to stabilize the fracture. If the nail matrix is injured, the nail should be removed and the matrix should be repaired. Epiphyseal fractures of the distal phalanx can easily be mistaken for distal interphalangeal joint dislocations, as they can present with apex dorsal angulation at the site of the fracture, as seen in this radiograph. There is usually an accompanying transverse laceration of the nail matrix, meaning the injury needs to be irrigated and requires debridement. Then the fracture should be reduced, the nail matrix repaired, and the nail replaced. Failure to recognize this fracture can result in a foreshortened digit with decreased range of motion, acute osteomyelitis, and/or septic arthritis. The middle and proximal phalanges can undergo extra-articular or articular fractures. Extra-articular fractures can occur in the neck, shaft, or base of the phalanx. Articular fractures can be condylar, comminuted, dorsal base, volar base, lateral base, or shaft fractures that extend into the joint. Fractures of the middle phalanx generally occur on the shaft and can be transverse, oblique, or spiral. All of these categories of fracture can be further classified as stable or unstable. Treatment of phalangeal shaft fractures depends on the stability and pattern of the fracture. Transverse, stable, and non-displaced fractures can be treated with 3 weeks of immobilization, preceding protected motion with buddy taping. Open reduction is required for unstable fractures such as this one. Oblique, spiral, and comminuted fractures often require open reduction and internal fixation. Proper fixation of these fractures is important to prevent malrotation, angulation, and/or shortening. If closed reduction is possible, fixation can be done with K-wires. If internal reduction is required, plates and screws can be used to provide good stability and early range of motion, but lag screws tend to be better tolerated. Both of these methods can disrupt soft tissue healing, however, which can lead to reduced range of motion post-operatively. Plates should only be used when absolutely necessary, such as with severe comminution, open fractures, or fractures associated with significant bone loss. When possible, external K-wire fixation placed mid-axially, such as seen here, is the best choice. Condylar fractures are those which involve the joint surface of the phalanx, often as a result of torsion and valgus-directed forces at the DIP or PIP joint. Condylar fractures can be divided into three types. Type 1 condylar fractures are stable, non-displaced unicondylar fractures. Type 2 condylar fractures are unstable unicondylar fractures, and type 3 condylar fractures are bicondylar or comminuted. Extra-articular base fractures can usually be treated with closed reduction and splinting. This fracture pattern is quite common in the proximal phalanx and usually leads to apex dorsal angulation of the fracture. A dorsal block splint with the MCP joints flexed can help maintain the reduction. If an acceptable reduction is not obtained with closed means, they can be treated with K-wire fixation. Intra-articular fractures of the base of the phalanx should also be externally reduced and splinted whenever possible. This is possible if there is no displacement of the fracture. Unstable oblique fractures of the base can also be reduced externally, but they require percutaneous pinning to stabilize. Open reduction internal fixation is required for displaced base fractures. The fixation can be accomplished using cortical screws and/or K-wires. Phalangeal fractures of the thumb are less common than similar fractures in other fingers. When occurring in the thumb, these fractures tend to be the result of a direct blow. Distal tuft and mallet fractures in the thumb are similar to those in the other phalanges and will not be discussed separately. Transverse fractures of the distal thumb phalanx, however, are managed differently than similar fractures in other distal phalanges due to displacement caused by the pull of the flexor pollicis longus tendon. These fractures can be unstable and may require reduction and fixation with percutaneous K-wires. Open reduction internal fixation is usually required for the rare longitudinal thumb phalanx fracture. The technique for this fixation is similar to that of longitudinal fractures of the other phalanges. If stable and not displaced, it is possible to manage both transverse and longitudinal proximal thumb phalanx fractures with immobilization by cast or protective splinting in a reliable patient. The thumb can also experience mallet injuries, which are treated similar to mallet injuries of other phalanges, which will be discussed presently. That's about it for phalangeal fractures. We will now discuss injuries of interphalangeal joints, beginning with mallet injuries. Mallet injuries are acute tendon injuries that may or may not involve the bone in the DIP joint. There are 4 types of mallet injury, illustrated in this table. Type 1 and 4 injuries are closed. Type 1 involve disruption of the extensor tendon and may or may not be associated with a small avulsion fracture, involving less than 20% of the articular surface. Type 4 are subclassified into 3 categories. 4A are pediatric transfascial fractures. 4B involve 20 to 50% of the articular surface and are a result of hyperflexion. And 4C involve at least 50% of the articular surface with associated distal phalanx volar subluxation and are a result of hyperextension and collateral ligament rupture. Type 2 and 3 mallet injuries are open injuries. Type 2 follow direct laceration of the digital extensor tendon insertion, and Type 3 follow abrasion or avulsion of the overlying soft tissue of the same distal insertion. Whenever possible, mallet injuries should be treated by strictly splinting the DIP in slight hyperextension for 6 to 8 weeks, or until there is no extensor lag, followed by 6 weeks of night splinting. All closed injuries with no subluxation of the distal phalanx, types 1, 4A, and 4B fractures, should be treated in this manner. Similar splinting should also be used for type 2 mallet injuries, following direct repair of the skin laceration and simultaneous tendon-skin approximation with deep passage of 3/0 or 4/0 nylon suture. The splint in these patients should only be removed temporarily for suture removal 12 to 14 days following repair. Splinting type 3 injuries is difficult as the tendon is often exposed following abrasion. These injuries require soft tissue coverage, often via a local flap. K-wires can be used across the DIP joint to hold it in extension in place of splinting. Type 4C injuries are more complex, requiring reduction of the subluxed distal phalanx and large articular fracture piece. Recall that this fracture piece is still attached to the extensor tendon. When the avulsion occurs, the tendon pulls the fracture piece 90 degrees to the normal joint axis. It is possible to perform a closed reduction of these fractures with percutaneous pinning if seen early, but open reduction is often necessary to achieve adequate reduction and joint surface articulation. Open reduction of a type 4C mallet injury involves first stabilizing the joint by pinning the distal phalanx in place with a transarticular wire. Then the dorsal fragment can be rotated back into its correct position and held in place with a K-wire or a small fragment screw. Debridement may be necessary to fully reduce the fragment. Once the fragment is reduced and the joint is stabilized, the extensor tendon can be repaired by advancing it onto the distal phalanx, where it is affixed with a suture anchor or tie-over button. The interphalangeal joints are bicondylar hinge joints, meaning there is only motion in one plane. The joints are stabilized with strong capsular and collateral ligaments. Dislocations of the interphalangeal joints occur following hyperextension, hyperflexion, lateral deviation, torsion, or impaction that puts stress on these ligaments, injuring them or making the joint unstable. Dorsal dislocations of the DIP joint, seen here in this lateral view X-ray, can be open or closed. Open dorsal dislocations are common and must be treated with irrigation of the joint, antibiotic prophylaxis, and surgical reduction. The joint is then stabilized with a splint in slight flexion for 2 to 3 weeks with protected motion starting 1 week after the reduction. Closed dorsal dislocations can be reduced externally through the longitudinal traction with distal phalanx in slight flexion. If the dislocation is irreducible, it is usually because there is a soft tissue, such as the volar plate or flexor tendon, in the joint space. Open reduction is required to clear the soft tissue. Volar dislocations of the DIP joint are less common than dorsal dislocations. Like closed dorsal dislocations, these injuries are also treated with closed reduction. They are then stabilized with a mallet-type splint for 2 to 3 weeks, followed by protective range of motion. Like dorsal dislocations, volar dislocations are occasionally irreducible as well, secondary to soft tissue being trapped in the joint space. With volar dislocation, it is usually the extensor tendon that is partially entrapped in the DIP joint. This requires open reduction to clear the soft tissue and reduce the joint. A jersey finger occurs after hyperextension of the DIP joint, such as may occur when a finger is caught in a football jersey. This results in flexor digitorum profundus tendon avulsion. These injuries do not involve dislocation of the joint, but they may be associated with bony fragment avulsion, type 3. Depending on the severity of the avulsion, the FDP tendon may retract all the way into the palm, type 1, or it may remain at the level of the PIP joint, type 2. Regardless of where the tendon retracts to, the treatment consists of anatomic reattachment of the FDP tendon. The tendon sheath is first identified via a zigzag incision in the finger from the area of insertion to just proximal to the PIP joint. An incision in the tendon sheath, just distal to the A2 pulley, is then made. If the retracted tendon is not identified here, then an incision must be made just proximal to the distal palmar crease to identify the retracted tendon in the tendon sheath proximal to the A1 pulley. The tendon is then repaired with a heavy, non-absorbable pull-out suture tied over a distally placed button. If there is bony fragment on the avulsed tendon, the tendon usually does not retract beyond the distal extent of the A4 pulley. If the bony fragment is large enough, it can be fixated to treat the injury. Dorsal PIP dislocations are the most common joint injury in the hand. These injuries result from hyperextension, which disrupts the volar plate attachment to the base of the middle phalanx. These dislocations range from simple hyperextension to joint subluxation to dislocation to fracture dislocation. Subluxation of the dorsal PIP joint results from simple hyperextension of the joint and tends to be associated with isolated volar plate injury. This type of injury can be identified by the V sign on lateral X-ray views, as seen here. To treat, the finger should be immobilized in slight flexion for 7 to 10 days, then buddy taped with early range of motion. Dorsal PIP dislocation often results from hyperextension and torsion of the collateral ligaments. Reduction of these dislocations can usually be accomplished with digital block and longitudinal traction. If the volar plate is blocking reduction, reduction can be achieved by reproducing the injury pattern. Hyperextension of the joint while applying pressure to the base of the middle phalanx can be successful. Once reduced, the joint must be stabilized and the reduction evaluated with radiographs. Stable joints can be immobilized for a brief period, then buddy taped with early range of motion, similar to the stabilization of a sublux joint. Unstable joints must be immobilized with an extension block splint, with the PIP blocked at 10 degrees short of instability. Progressive increase in motion is then done in increments of 10 degrees of extension weekly. Stable fracture dislocations, involving less than 30% of the joint surface, can be reduced and splinted with the extension blocking splint. Unstable fracture dislocations, involving more than 30% of the joint surface or with subluxation, are more difficult to treat. They can occasionally be treated with a dynamic traction splint, allowing early range of motion, but frequently require operative treatment. Open reduction internal fixation is associated with a high complication rate, such as infection, joint stiffness, arthritis, or instability. Because of this, ORIF should be used only if the fracture or dislocation is irreducible. Volar PIP dislocations are less common and often more severe than dorsal PIP dislocations. These injuries are the result of compression and rotation of the PIP joint in flexion and involve disruption of the central slip as well as injury to at least one collateral ligament. Simple volar dislocations and stable fracture dislocations involving less than 40% of the articular surface can be treated non-surgically with reduction via longitudinal traction and extension splinting for 2 to 3 weeks, followed by protected range of motion. I hope this has been helpful and informative. Thank you for listening to our Phalangeal Injuries webcast. You can find more helpful webcasts, including a detailed one on metacarpal injuries, on our website.